Welcome to Grow Them Right, podcast where we discuss how to prevent health issues from infancy. I'm Dr. Roche, a dentist and a mother of two. As a dentist, my expertise are in oral health, and I'm committed to continuing education. I also have a keen interest in preventative health. So in this podcast, I ask questions of experts, explore their insights, and discuss practical tips on how we can help our children grow healthy and strong right from the start. The whole idea for this podcast is to elevate the conversation and allow you, the listener, to make more informed decisions. I need to emphasize that these podcasts are not a substitute for medical advice. If you have any specific health concerns for you or your loved ones, please speak to your own medical professionals. I hope you find this space useful, and if you do, please take a second to subscribe and share with your friends. And together, let's grow them right.
You might have wondered if your kids need their wisdom teeth out, or your teenagers will need jaw surgery to correct their bite. You might have experienced this journey as a teenager yourselves. What is the best course of action, and can surgical intervention be avoided? To shed light on this matter, I have with me Dr. Ramon, an Adelaide-based specialist maxillofacial surgeon with extensive international experience. Ramon runs his very busy day surgery clinic in Hyde Park, and apart from being at the forefront of provision of care, is also involved in training the next generation of surgeons. Dr. Ramon, welcome to the program.
Thank you so much, Rosh. Wonderful to be here.
Thank you. So to begin with, tell us a little bit about what you do.
I'm a specialist oral and maxillofacial surgeon. Our specialty really centers or lives at the intersection of medicine and dentistry. So the field of surgery encompasses a lot of what we would consider traditional oral surgery, tooth extractions, impacted teeth, cysts, these kinds of pathologies, but also spans all the way from there up to trauma, major reconstructive surgery, cancer, and related disciplines. Like in my case, I'm interested in cosmetic surgery, and so that means rhinoplasty, skin cancer, facelifts, the whole gamut, the whole spectrum of it. So
you guys need to study dentistry as well as medicine?
Yeah.
And well as the surgical training?
Yeah, that's right.
Is this the longest medical training that there is?
As far as I know, it is the longest pathway to become a surgeon because of that need to do 2 primary degrees, and there isn't really, unfortunately, any other way to do it. You have to have both degrees, and I think the changes with education now that both dentistry and medicine are graduate degrees now. I did those 2 degrees in 9 years, but I think now it would take 11 in certain pathways, because you've got to do your science degree first, and then your dental degree, and then your medical degree, or whichever.
And then probably a PhD on top of it.
Well, a lot of guys are doing that as a PhD now as well, because it's become so competitive. So
very highly trained.
Yeah, I would say so. Yeah.
This podcast is for young parents, and it's basically to give them a little bit of an idea as to how to grow the children in the right path, right trajectory of growth, so that they avoid those major surgeries. So what I'm interested in asking you is, when it comes to correction of the bite, what is the role of the oral surgeon when it comes to, making sure the individual has a good bite to function and to have for life?
Certainly a very big question. I think that there are many elements that tie into it, because you're looking at growth and development, you're looking at environment, you're looking at habits, lifestyles, and also questions about image and psychology. So there's a lot of things that tie into it. My role as a surgical provider is interlocking with other providers to try to deliver a outcome for people that is as ideal as we can, according to our current understanding and current technology. And so the process itself is a bit complicated, but I typically get involved in cases where someone has perhaps already determined, I think teeth don't look right, and perhaps they've had a consultation with an orthodontist or general dentist most often. And increasingly these days, referrals from their general practitioners as well. And the awareness of jaw and bite issues it has been increasing, I think. And so people may be even just thinking, I don't think this is right, and then coming to seek an opinion. And I would see people at that point and sort of take them through the conversation and discuss the issues and see what problems they may be dealing with and how to tackle that.
So like, for example, from my point of view as a general practitioner dentist, we see patients that have a receded chin, or they might have an underbite where the chin actually sits too far forward. And these are the cases where you have to deal with them. Now, as the individual is growing, if you see there's early signs, we might be able to modify the growth, correct? Can we talk a little bit about that trajectory of growth modification that might prevent the need for surgery?
Yeah. Growth modification has quite a long history, actually, going right back way to the late 19th century. I think as early as then, Angle and many orthodontists that he trained believed a lot in growth modification, and they seemed to achieve very good results. And it was only later, through more rigorous application of X-ray imaging, study, cephalometrics, that it was discovered that a lot of the changes being produced were dental and weren't actually changing the skeletal growth pattern. Initially the view was a lot of the growth is environmentally controlled.
Yes.
And therefore we should be able to control it. And then once the discovery of the relatively unchanged growth but changed tooth positions was discovered, that view switched and people started to think, well, it's all genetically controlled. We can't do anything about it. This was sort of in the 50s and 60s, and growth modification completely fell out of favor in particularly North America. But it didn't happen that way in Europe. A lot of orthodontists continued to do that. And so you would see two different schools of data coming through. Then I think again in the 80s and 90s, growth modification started to take more favor again. And that was a result of doctors across the Atlantic looking at each other's results. And so there was a resurgence and I think a tempering, and it's a process of iteration that's been going on for more than 100 years, and people are sort of learning more and more over time. Fundamentally, a lot of the goals of growth modification are trying to enhance or accelerate growth if there is a deficient growth, and trying to change or modify the direction of growth if there is excessive growth. And there are appliances that can be used to achieve that. I think the most successful of those would probably be upper jaw expansion, where we know that expansion can be accomplished, and it's usually a combination of skeletal expansion, so widening the jaw bone, but there's also a element of dental compensation, just adaptation of the teeth. And the adaptability of the teeth is one of the reasons that orthodontics can even occur, because they will respond to changes in movement.
And then the other devices are like, the twin blocks, where they position the chin forward to stimulate growth of the mandible, or perhaps, those reverse headgears where the top jaw is brought forward, so that we've got more volume in the mid face. So the prominence of the chin is minimized. It's a very, very interesting topic. And, one of the discussions that I have with patients is that if you if we see early signs of this developing in a child, perhaps it's good to at least get that opinion from an orthodontist to see whether this is a possibility for that child. And instead of leaving it until they're 17 or 18, and then that boat has sailed. Do we see that most of the surgeries happen in the later teen or early adulthood when these procedures are needed?
Certainly surgery, especially definitive surgical procedures where you're trying to achieve a certain outcome, are usually preferred to be delayed until majority of growth is stopped. Mainly because if you do surgery in a growing child, there are a number of challenges. First of all, if you're in mixed dentition, there's a possibility of damaging permanent teeth because you can't see them.
That's right.
And if you have an uncertain growth potential, then it's difficult to predict. And I think particularly with situations where the lower jaw growth is excessive or too much, that is certainly difficult to tackle the surgery early because you would have a pretty substantial chance of growth occurring after you've had surgery. And then what do? You have to redo it. So there are certain situations where I might prefer, for instance, to delay surgery until 19, 20, 21, and certain situations where perhaps surgery might be possible to be done earlier. It's always tailored to an individual, and it's difficult to come up with a specific general protocol, but you do have to tailor it according to the specific growth characteristics that you're seeing. Certainly, I see all sorts in the spectrum. I see upper jaw deficiency, lower jaw deficiency, excess, mixtures of both.
That's right.
And
it's such a life-changing process for a lot of these patients in terms of general health, because it impacts sleep as well as the psychological component that you mentioned in terms of self-confidence and presentation and interactions.
Absolutely. I think it is definitely one of the most life-changing surgeries. A lot of the patients that I see will be late teens and feeling self-conscious about it. And it's kind of magical in how many different things orthognathic surgery, for instance, touches, because it's simultaneously improving appearance. They frequently feel that breathing is improved. It's just kind of astonishing how many things can change in one maneuver.
But I've seen the slides of your presentations, and I know how serious and how involved these surgeries are. And to be honest, I don't wish these surgeries upon anyone. I mean, if you have to, of course, it's life-changing. But if you can avoid it and if you can prevent it, and that's the goal of this podcast, how do we grow them right? So we don't need medical intervention. Tell me a little bit about the anthropology of the bite and whether we are actually seeing an increase in deficiency of the bone when it comes to the craniofacial skeleton. Do you see a pattern emerging?
There certainly seems to be a trend if you look at the historical anthropological records towards smaller jaws in humans. If you look at early humans from the early emergence of Homo sapiens after Neanderthals, the jaw sizes have been getting smaller, and associated with that you see a lot of secondary order effects. For instance, increasing rates of impacted wisdom teeth, increased crowding, and these issues become everyday, day-to-day problems that I deal with. So every day I would see people with impacted wisdom teeth. They're getting pain because there's pressure, difficulty cleaning them, just not enough space to house the wisdom teeth in the jaws. And I'll frequently be removing them because they're a problem. And the questions about why are difficult to answer. And I think it's something that is going to be a very dense area for scientific exploration. Certainly interesting developments. I recall there was a paper in Tokyo I think, within the last 10 years or so, looking at jaw growth in rats, and it found that feeding them different textured diets changed the growth potential and the growth that was seen in the jaw. So if they were given softer diets, they were seen to have less growth, and harder diets, more growth in the jaws. And I think there could be a parallel with our current modern lifestyles, where I would say for our earlier civilizations, teeth were a tool. They were used a lot more proactively, and you would see a lot more wear on the teeth, but perhaps the jaw growth was larger and heavier. And today, where our diets are a lot more refined and softer texture, and you see less growth. It's an interesting question. The working theory would be just the physical stimulation from working the jaw muscles.
They call it the functional matrix theory.
But more specifically, just the action of heavy use of the jaw muscles to eat is somehow stimulating the jaw to grow in all dimensions, width and length. I remember seeing in a textbook years ago a very old photograph of an Indigenous Australian man eating a kangaroo leg, and he was just tearing into it. He every muscle in his pectoralis, shoulder, everything, every fiber of his being was being used to pull that open. And you would see lots of flat, worn teeth, but very broad jaws. And they wouldn't have much sign at all of crowding. So interesting phenomenon, and I think something that really should be looked into. And I think if you were thinking as a parent, what can I do? I think just providing a broad array of nutritious, different textured
real
foods.
Food.
Yes.
Non-processed.
Yeah. Not only like a fruit smoothie thing, but like a raw apple or carrots or something, just to give a little bit of something. That's something that you could do every day.
That's right.
Without much effort to
and of course, there's also plenty of evidence associating breastfeeding itself with better jaw growth because of that muscle action that is required for breastfeeding. That, I mean, in the first 2 years of life, if breastfeeding is prominent way of feeding.
I mean, we could spend a whole week talking about breastfeeding.
Yes, and also like, the book Breath, I don't know if you read that book or not, is a investigative journalist, James Nestor, that has explored that and goes to that big cemetery and Paris and looks at the skulls before the Industrial Revolution and compares it with after, and with the introduction of knife and fork and softer diet, you see a massive change in the size of the jaw. It's quite fascinating. But I mean, the thing that I always suggest to patients, which costs nothing, is to be aware of the diet of the children, and
I think so,
and get them to eat the real food.
I think for any young growing person, just providing that care and attention and guidance, and it may be a little bit more difficult, but potentially has a large impact. Who knows?
And you spoke about palatal expansion as one of the things that is more commonly done, and we get good results, both change of the shape and size of the bone of the palate, as well as getting the teeth out of the way and providing more room for the tongue. And that's one of the things that I've been learning about, the association of the jaws with sleep. Now, I know that the oral surgeons have a role to play when it comes to sleep surgery. Can we explore that a little bit?
Sleep is one of the most complex topics that we have to deal with in modern medicine, because it touches on so many aspects: breathing, the effect on the brain, the effect on various organ systems, cardiovascular system, mood, and then the effect and relationship with the airway and growth. and there's been many different treatments described to manage poor sleep-related breathing, which is one of the most common issues with sleep. It's not the only issue with sleep, of course, many different reasons, but when you get obstructed airways during sleep, that is one of the major areas. And there's a lot of different treatments and a number of different surgeries described. What my specialty, an oral maxillofacial surgeon, would classically be offering patients is what's known as maxillomandibular advancement surgery, because the anatomy of the airway is one of the issues that's contributing to disordered breathing during sleep. And there are many sites of obstruction that can occur. You can get obstruction in the nose, in the back of the throat, what we call the pharynx, behind the tongue, and even below the tongue. And so there are many different treatments that have been described to try to address all these various things. So for instance, people who have a blocked nose may have a nasal or sinus surgery, septoplasty to try to remove blockages in the nose, which is a common issue for many people.
Yes.
People have had uvuloplasty, UPPP, to try to address snoring and obstructed breathing in the back of the throat.
That's when the soft palate is
soft
reduced.
palate and tonsils, adenoids, that sort of area. There have been devices implanting little stimulators to make the tongue
forward,
protrude, and various chin operations to try to suspend that. And all of these are targeting various different levels of obstruction in the upper airway. What maxillomandibular advancement does is it kind of treats all of them at once. So by moving the jaw and expanding the airway and sort of splinting it and holding it open wider, because of the nature of where the surgery is done, it is changing the dynamics of the nasal passage and usually opening it quite a bit. It's pulling the soft palate forward and opening up that space. It's pulling the tongue forward and just enlarging that airway at multiple levels. And it's really the only surgery that can do all of those levels in one procedure.
And it entails expansion of the palate, bringing the palate forward. So you basically need to separate the bone of the maxilla, bring it forward, and also do the same with the lower jaw. Correct? And expansion. And the expansion of the palate means that the nose is more patent.
Yeah. Well, you can separately widen the palate in the same surgery, but you don't always have to. Just by bringing the upper jaw forward, you have now shortened the distance of the nasal passage, because you have brought the palatal bone forward and the soft palate, and so that the distance traveling through the nose, which is a major site of resistance, is shortened. So it's proportional to the length of it's like breathing through a tube. So it does improve that by reducing the resistance. And when you do the surgery, you frequently modify the architecture of the upper jaw and the parts of the sinuses surgically anyway, and that helps as well to create additional space and reduces the obstruction.
It's fascinating stuff. A lot of times when I look in patients' mouths, I see the anatomy of sleep apnea, because I see the size of the tongue and I see the size of the space that is housing the tongue. And so, just becoming aware of the anatomy, I think is really important for parents. But of course, we don't want to be alarmist. We don't want to, be overdoing things. But I think I still feel that there's a lot of things that we can do when the children are much younger to grow them in a better trajectory. Now, finally, the question of wisdom teeth. We see so many wisdom teeth, and it's always a question for parents of teens. Every wisdom tooth that is impacted needs to come out, or how do we decide?
Yeah, it's controversial. Let's just say that. I would say that in my practice at least, I see a wide age spectrum, and you will see people early tweens even, 11, 12, 13, with early signs of wisdom teeth that I can predict will become impacted. I see them at the more typical ages, 18, 19, 20, but I also see them across the full age spectrum, 30s, 40s, 50s. The oldest person I ever had to take wisdom tooth out was 100 years old.
Oh, wow.
So I have seen the full spectrum of it. And what I came down to it was, if there isn't space for the wisdom teeth, there's probably never going to be space. And I personally prefer to take wisdom teeth out preventatively for many people. There's lots of different philosophies out there. We should acknowledge that. And certainly in different countries, and particularly in the UK, they will not be in favour of that. But I feel personally that the surgery is a lot easier to perform when you're at that sort of teenage stage of life, for a number of reasons. One of them being just the bone is easier to work with, and the roots haven't fully grown. It just makes it a little bit easier to get the surgery out, or get the surgery done and get the wisdom teeth out. And I think it also, because it's almost rubbery in quality, the teeth kind of spring out of the bone. And I think that at that age, kids heal really fast. They recover very well.
Less responsibility as well.
Yeah, I think that. I think whereas if I had to take your wisdom teeth out, or mine, or someone, the change in the difficulty is a huge leap up, and it certainly makes you sort of become a bit more circumspect. So I tend to have the philosophy of, up to an arbitrary age threshold, and it is arbitrary, I'll tend to remove them in a preventative way, preemptive removal. And I think once you've passed an age threshold, and it will be different for any surgeon, people might switch to being a little bit more selective about treatment. I think there are other reasons as well. I mean, you don't want to have the situation of, now I've got a very painful tooth, or it's a Friday night and it's crisis mode.
Yes, the crisis mode is very hard to manage. Those sorts of things can sort of interrupt you if you've got a family at that stage of life. Or you're flying to Bali, or you have a conference next week.
It happens every week. There's someone like that.
And we see so many cases that is like that. And of course, when they're infected, they're very difficult to anesthetize. They're difficult
it just makes for a more difficult recovery, certainly, and a sort of a more intimidating experience.
And then the devastating thing is that when the teeth next door to the wisdom tooth number 7, second molars, become decayed at the root surface where the wisdom tooth is impacting, and then that tooth will need a root canal treatment, and that's really, really devastating to give that news to the patient.
You've lost
as well.
2 for the price of 1, so to speak, because it could have been prevented.
So the message is that parents should really get that checked.
I think so. I think certainly in Australia, there's no reason to not at least have awareness of it. I think that we have the capability to deliver care safely and effectively.
That's right.
I think it'll be different in certain parts of the world, but here I don't think we have those concerns.
So the other question that is very interesting is, correcting the bite only a cosmetic issue?
Great question. And I'm happy to say the answer is no. This surgery was fundamentally conceived of and designed to treat a poor bite. And it's a very, very long history, which I won't go into at the moment. But fundamentally, it is designed to fix a functional problem. Your bite is supposed to work in a certain way. Your teeth are supposed to mesh together. It's all supposed to work as part of a system. And if it's not proportionate, if the jaws are just way too big or too small, then you're not having that correct arrangement and balance in the face. So it's not a cosmetic surgery. But people always ask, but it looks like it is, because it has such an incredibly powerful change to the facial appearance. And that's just the happy side effect. It's like the bonus. And people go, well, why? And I say to them, well, because good facial symmetry and good proportions look good. That's it.
And form follows function.
Yeah, it's as simple as that.
Versa.
Once you get it all balanced, it just seems to, you look like a different person. Yeah. And so fortunately it's not cosmetic surgery, and it's all can be done in hospital and through insurance and properly managed that way.
Another question that I had for you, looking at the bite, and especially with the teenage population, is the temporomandibular disorder. And just wanted your opinion whether that actually relates to poor bite, because I get a lot of teenagers, especially girls, where they come to me with, headaches, poor sleep, they can't concentrate at school, and they often have this pain, unspecified sometimes. And, often they are diagnosed as migraine, and they often are on medication for it, or even sometimes antidepressants. And I just wonder whether we can explore how a poor bite might lead to those kind of symptoms.
I think that the issue of joint function and joint dysfunction is it's another huge topic. There's a lot of associations with various chronic health conditions. So frequently you would see increased association of mood disorders with joint function problems. You may see an association with chronic illness. It's certainly associated with increasing age. We see more problems. And unfortunately, women just massively outnumber men in terms of the frequency of these jaw-related issues. I think it's like 9 to 1 or something.
That's right. Yeah. Fascinating.
So probably hormonal influences.
Has to be.
And so it's such a huge multifaceted thing. It requires a multifaceted approach. I think that if you've got particularly poor bite, where the teeth are sort of hitting into each other in a traumatic way, that certainly is something worthy of addressing as part of a holistic approach.
Multifactorial.
Yeah, correct.
One piece of the puzzle.
Yeah, because you want to try to eradicate as many contributing factors as you can to help optimize and boost the health, along with all the other things that we sort of touched on, and mental health in itself, just boosting that resilience to help people is just an increasing challenge. To be honest,
and it is very, very difficult to be happy if you have chronic pain or if you haven't slept well.
So having the right people, the right teams, and constant attitude and willingness to learn, it's something we should.
So important, and also us as health professionals to be learning from each other. When a patient goes to a psychiatrist with these kind of issues, without investigating what the contributing factor might be, they might go on a tangent that could be avoided as well.
Yeah, or just reducing the quality of the outcomes that they're getting because things are perhaps overlooked or lack of awareness.
That's right.
It's really hard, and I think it's pushing us more and more towards an interdisciplinary approach to treating many chronic health issues, because it's difficult for any one person, impossible probably, to be able to handle and encompass everything.
That's right.
And it requires the right teams of people.
And as my dear Professor Goss used to say, you can't diagnose something that you don't know about.
Yeah.
I mean, sometimes I get patients that have had a history of ear pain, and then finally get to the dentist, and you touch the TMJ, and it's so sore, but they've been on antibiotics, several rounds of it for ear issues, but it's nothing to do with the ear.
Yeah.
So it is really, really fascinating.
Yeah, we must continue to do better. It's just
absolutely. Thank you so much for this very fascinating space and talk.
Oh, thank you.
Yeah, continue to learn more and more from you. Thank you so much.
Absolute pleasure to be on here anytime.
Thank you.